Okay, let's talk about the lower GI, starting with the lower GI bleed. So whenever you're assessing the patient's GI elimination, so to speak, let's start with the stool. Whenever a patient presents with melena, it means basically the stool is black, and it might be an indication of an upper GI bleed. And so the blood has been in the system for a while, so it's making its way down into the stool, and that's why it comes out dark. And steatorrhea is basically presence of fatty stool. This could be a side effect of medications or possibly a malabsorption problem. And so this has to be documented, and physician basically made aware of this. And then clay-colored stools, this could be an indication of blockage of bile. So basically the bile is not making its way into the GI tract, and that's why the stool is coming out clay. And there could be other reasons too. Hematochezia, this is bright red blood per rectum. I think you guys have seen that abbreviation in the hospital. Bright red blood per rectum. And this could be like, let's say a patient has internal hemorrhoids and they go to have a bowel movement and the hemorrhoids burst, and so then you see the bright red blood in the stool. And then coffee grounds, this is referring to the color of the patient's emesis. And so whenever they're having coffee ground vomit, it means it might be possible that there's a slow bleed, and so the blood is sitting in there for a while, and so when they throw up, then it appears like it's coffee ground. And then hematocrit emesis is a bright red blood vomit, and so it could be an indicative of fast bleed. So these patients have to be evaluated for the cause of bleeding in all of them. Whenever a patient presents with acute abdominal pain, we want to rule out all kinds of things. And so these are the areas that the possible colorectal cancer locations. And so in the transverse colon, a patient presents with pain, obstruction, change in bowel habits, and then also anemia. And then in the ascending colon, in the rectum, and descending colon. As you can see, the most common thing is pain, change in bowel habits, and anemia. It seems to be the colorectal cancer might be causing bleeding, and so that's why a patient becomes anemic. And so, like we were talking about bright red blood, the lower you go, the more likely patient will be having red blood, versus if it is in the ascending colon or transverse colon, a patient will probably present with melena, which is black stool. So here's some of the diagnostic studies. So barium patient is given a radiopeg, they should be NPO 6 to 8 hours before the test, basically help clear the GI system. Clear liquids 24 hours before the test, and bowel cleansing. The most common cleansing occurs, like, I don't know, if the patient is admitted in the hospital, we usually start the cleansing like the day before, and they have to drink the laxative overnight. And patients should be given laxatives to basically get rid of the barium, and then the barium stool is white. So whenever you have a patient and you're assessing the stool color and you find that it's white, basically you want to find out if they've had a barium study done in the last day or two. Another diagnostic study is a CT scan. If it's going to be given with contrast, for the most part, if it's an emergency, we do the IV contrast. And whenever they get the IV contrast, patient should also be hopefully not have any problems with their kidney function, because it is it goes through the kidneys to clear the system. And with oral contrast, they get about 250 ml, which is 2 to 3 hours prior to the scan. So the purpose of the oral contrast, for the most part, is if they're trying to assess for blockage in the colon. And so if they drink the contrast 2 to 3 hours before the scan can tell if the contrast is not coming through, it's not traveling all the way, basically. And then for IV access, patient need at least a 20 gauge to administer the IV contrast. And this is another study, ERCP, endoscopic retrograde cholangiography. So just so you know, for this procedure, the patient has to be NPO before and after. And I will say that again. The ERCP patient has to be NPO before and after. So for the ERCP, evaluate obstructive jaundice, and then examine pancreatic common bile, cystic, and hepatic ducts. And it also can be used to remove the common bile duct stones. So NPO, and that time me repeating, NPO before and after the procedure. So the purpose of patient being NPO after the procedure is to make sure that they get their gag reflex back, just so they don't aspirate. A consent should be in place because this is invasive. And after the procedure, we need to assess for acute abdominal pain and hypotension, and make sure that if patient is allergic to dye, that it is indicated in their chart. And this is the most common test to evaluate for GI bleeding. So it can it's good for visualizing the esophagus, the stomach, and the duodenum. It can be used to diagnose a hiatal hernia, and then also whenever they do an EGD, they can do biopsy, locate and treat the upper GI bleed, and then they can also do thermotherapy, sclerotherapy, and band ligation. The limitation of an EGD is basically that it only goes so far, and so if they want to visualize the whole GI system, the best gold standard will be a colonoscopy. So your role during an EGD is make sure a patient has a consent. And for the nurses that work in the GI lab, the patient positioning is left side. And then also they need to be sedated for the procedure. Sometimes this is a conscious sedation procedure, but if they need general anesthesia, then different arrangements have to be made because anesthesia has to be present to do general anesthesia. There's some patients that cannot tolerate conscious sedation. So basically, conscious sedation is where medications are given, but patient is aware of what's going on, but they get medications to relax them and hopefully not feel pain. And this is also one of those, the patient has to be NP after the procedure for the return of the reflex. For the most part, whenever patients go for these procedures, when they come back to the floor, we start them on a diet right away because I'll say probably an hour to 2 hours after the procedure. So they get their food back. And you can test the patient's gag reflex by basically giving them a small sip of water. Not too much, just to make sure that they don't aspirate. Like I was saying, the colonoscopy is basically the gold standard for visualizing the GI system. It is also the primary tool for screening colon cancer. Those of us that are going to be turning 50 soon, we should be looking forward to this. And then sigmoidoscopy is almost like an EGD, but it's coming from the other end. And so it only visualizes the rectum and descending colon. So if something is suspected on that, and this is the test that will be done, and if they don't find concluding diagnosis, then they'll have to go and do a whole colon scope, which is the colonoscopy. So nursing considerations for colonoscopy, NPO except for clear liquids for 24 hours prior to the test. And then bowel prep, tap enemas until the stool is clear. We use Go Lightly. Patients can take 2 liters, 2 to 4 liters for the procedure, and they have to stop drinking the Go Lightly 2 hours before the procedure. Like I mentioned before, NPO post-procedure until fully awake and sedation wears off, and there has to be consent on file. Here some of the different types of bowel obstructions. It could be from adhesion, strangulated inguinal hernia, ileocecal intussusception, which is that, and then intussusception from polyps, which is that, mesenteric occlusion, neoplasm, volvulus of the sigmoid colon, which is appearing right there. This is a short video of capsule endoscopy that if you click on it, you guys can watch that on your own. And then types of obstruction. These are mechanical. Basically, this is a stricture from a previous surgery, cancer, or intussusception, like shown in the picture right there. Non-mechanical, it could be partial or complete, and it's related to peristalsis, common after large abdominal surgeries with no return of bowel function within 72 hours. There's risk for paralytic ileus. And this is why it's very important for patients that have undergone any form of GI surgery that we make sure that they are passing gas. And to help them with that, we need to have them up and about. And as a nurse, you should be assessing bowel sounds, like seriously, to make sure that it doesn't lead to a paralytic ileus. Other causes could be, for the non-mechanical obstruction, could be sepsis, electrolyte imbalance, or narcotic administration. This is very a notorious easy way for patients to get constipated and end up with an obstruction. So whenever patients are admitted, we need to make sure that they're taking stool softeners. Make sure you provide the education, because sometimes patients are not aware that narcotics can cause constipation. Look at that. That is a bowl full of stool. Blockage of large intestine caused by diverticulum. So basically, this is preventing all this from coming down, and so patient might end up having nausea and vomiting because this is all backed up. Some of the signs and symptoms of bowel obstruction is abdominal distension, abdominal pain, hypokalemia and hyponatremia, nausea and vomiting, obstipation. The bowel sounds will sound high-pitched and then they disappear. So make sure you're doing that check of listening to the bowel sounds, and then also talking to the patient, assessing for nausea and vomiting, and you're palpitating the abdomen to make sure that there is no distension, because you will feel it. If there is a change when you do assessment in the morning, and then say by midday you do another assessment and there is a change, that's cause for concern, and you should be notifying the doctor. That doesn't look normal at all. Looks like it's filled with something, and there's some form of obstruction right there. So nursing care and treatment in bowel obstruction, the most common orders you'll get is insertion of an NG tube to basically decompress the stomach. Monitor electrolytes. See this part? It's highlighted in red. Keep note of that. Monitor acid-base balance, antibiotics, assessment of pain, monitor white count. We need to do this because if, say, for example, there's a rupture and patients get in an infection, the white count might be able to give us an idea. And anticipate surgical intervention for mechanical bowel obstruction. So, nursing diagnosis, your favorite. One of those will be ineffective tissue perfusion, fluid and electrolyte imbalance. Because of the decompression using the NG tube, we're basically sucking out everything in their stomach. And so in that case, we want to monitor their potassium and magnesium, and then make sure you're assessing for pain. And like I mentioned before on the other slide, these patients will be fluid deficient. So our priority diagnosis for these patients will be deficient fluid volume. And I repeat, fluid deficient. Here's some of the tubes that we use. The saline sump can be used for irrigation, decompression. The most commonly one for decompression we use is 16 to 18 French. Said the Miller Abbott. I haven't seen this yet in the hospital, but it is inserted by a physician. The weighted tip opens up blockage as it moves through the gut and can also be used for decompression. Yeah, like right there. Some of the risk factors that, oh wait, it's not a risk factor. Actually, this is a completely different thing we're going to talk about. Acute peritonitis. So the risk factors for this are bowel rupture, post-operative leak, or peritoneal dialysis. Peritonitis, otherwise known as hot belly. So basically, we have to give these patients normal saline with potassium and possibly antibiotics if they will be having a fever, nausea and vomiting, anorexia. So we need to give them antibiotics and also IV fluids because remember, they're gonna be dry. So you want to find out what's causing the problem and eliminate the cause. And then antibiotics, like I mentioned, IV fluids. And then we want a tube to decompress the abdomen, to lower the abdominal distension. And these are some of the symptoms: rebound tenderness, abdominal rigidity, abdominal distension, The WBCs will be increased. The pulse will be increased. Elevated blood pressure. Patient will be dehydrated and decreased bowel sounds. Sleeping bowels. So risk factors: abdominal surgery, ectopic pregnancy, perforation from trauma, ulcer, appendix rupture, diverticulum. So for the nurse, fluid and electrolyte balance and GI distension assessment. Eliminate the infection process, prevent complications, immobility, pulmonary infection. So basically, take care of these patients. And now let's talk about inflammatory bowel disease. This is ulcerative colitis and Crohn's disease. So ulcerative colitis, patients present with profuse diarrhea. Stools may have pus and blood, and the patients will have abdominal cramping prior to bowel movement, and they will have fluid and electrolyte imbalance, and it can lead to toxic megacolon. As for Crohn's disease, the stools contain mucus and pus, but rarely blood. So that's the main difference between ulcerative colitis and Crohn's disease. There is no blood in Crohn's disease. And then Crohn's disease patient will present with diffuse right lower quadrant pain, and then they will also have a fluid and electrolyte imbalance. Here is a figure that shows patterns of Crohn's disease and ulcerative colitis, and then ulcers and wall thickenings, conformations of ulcers and wall thickenings. So the diagnosis of inflammatory bowel disease is based on history. A patient should have a stool culture to rule out infection, barium enema, and then if they present with elevated ESR and sigmoidoscopy and colonoscopy, our favorite. So treatment is based on severity of the symptoms, and so the most common one is corticosteroids to reduce the inflammatory process, and then there's also immunosuppressive agents, anticholinergics, metamizole. Surgical intervention, this is avoided because of recurrence in Crohn's. In ulcerative colitis, patients can end up with an ileostomy or ileoanal anastomosis. Patients get antibiotics during acute flares, and antibiotics include flagyl, and then aspirin derivatives for ulcerative colitis. Biologic therapies include anti-TNF agents as listed there. Patients should be monitored for signs of infection, and the side effects include headache, nausea, joint pain, and abdominal pain. You can review those. and review that. Let's talk about nursing care. During inflammation, patients are put on bowel rest. Depending on the severity of it and how long they need the bowel rest, the patients can end up with a central line and a central line and ear and TPN. Something is malfunctioning on my computer. I'm telling you, technology is going to be the death of me. I do not like technology. I'd rather be giving this lecture in person. The time it takes me to figure this all out before I can actually sit down and do this. My kids are about to kick me out of my own house because I keep begging them for help. Anyway, we're talking about the TPN. So TPN is only initiated if patients' symptoms are severe and they need longer bowel rest. And so because TPN is very expensive, and then the patient will need a central line, and it increases the risk for infection for these patients. And so we avoid TPN as much as possible, and only when it's absolutely necessary is it initiated. The diet should be low residue, bland, high calorie and high protein, liberal fluid and salt intake, multivitamins and mineral supplements should be included. And also, since this is like a lifelong disease, we want to help patients develop effective coping strategies and possibly support groups if they're open to it, and make community referrals. Okay, since you are not here to respond to my questions, I guess I'll be reading and I'll be the audience. So after teaching the patient with IBS about dietary modifications, the nurse determines that teaching was effective when the patient chooses which of the following menus: baked cod, baked sweet potato, and canned pears. Or do we go with barbecued brisket, coleslaw, baked beans, and angel food cake? Or do we go with fried shrimp with cocktail sauce, corn on the cob, and a fruit roll-up? Or turkey with cheese on a whole wheat bun, French fries, and an orange? So, we need the patient to avoid fatty foods, and so I think we'll go with the baked cod, baked sweet potato, and canned pears. Which of the following comments made by the patient indicates that additional instruction about the care of a new ileostomy is needed? I should change the appliance daily to prevent odors. When I change the appliance, I should check the skin for irritation. I should clean around the stomach with mild soap and water and pat dry. I will need to alter the appliance opening when the stomach becomes smaller as the area heals. So when it comes to ileostomy, they don't need to be changed daily. They can stay in place up to 7 days. So the answer will be 1. And since we're talking about ileostomies, so for when you're assessing an ileostomy, I think we'll cover this soon. I will hold my thought, but there's a question on that. This is a diagram of diverticular disease. You can review that. So basically, the diverticulosis, there are small herniations in the digestive tract. And then diverticulitis is one or more pouches that become inflamed, infected, or ruptured. So this is a very important slide, and so review it and understand it. So pain in left lower quadrant with a sudden onset, rectal bleeding, fever, abdominal bloating, and nausea. So basically, if you're suspecting acute diverticulitis, the patient will have a fever and they will have abdominal tenderness. So that will indicate possible rupture of diverticular. Yes, diverticular. That's one. So collaborative treatment. In mild cases, the bowel needs to be rested and then it may resolve on its own. But in more severe cases, patient kept NPO, we put them on IV fluids and initiate antibiotics, monitor for bowel obstruction, rupture, and then they'll be in extreme pain, so we want to make sure they're on pain medications. And since we're resting the bowels, we'll be giving them IV pain medications. And what does that say? IV pain meds, for the most part, unless it is IV Tylenol, for the most part, we're giving narcotics, which could also lead to constipation. So we have to be aware of that. And then surgical intervention necessary if there's a rupture. Because the rupture will lead to bleeding, infection, and like I mentioned before, acute diverticulitis as a result of perforation will present itself with abdominal tenderness and increased temperature. So, patient education in diverticular disease. Patients should eat more fiber to prevent the disease. Avoid nuts, seeds, and popcorn because this will tend to hang out in those little pockets in the colon. Drink plenty of fluids, exercise regularly, prevent constipation, and low residue diet during flares when they want to manage this at home. Okay, now moving on to colorectal cancer. This is the third most common form of cancer, and it's the second leading cause of cancer-related death in America. 85% of colorectal cancers arise from adenomatous polyps. It is more common in men than women. Family or personal history of colorectal cancer, increased age, colorectal polyps, inflammatory bowel disease, and then lifestyle factors include obesity, smoking, alcohol, and large amounts of red meat. So the incidence of cancer in the transverse colon, 11% in men and 13% in the females. In the ascending colon, men is 22% and the female 27%. Descending colon 6%. It doesn't say whether female or men. Sigmoid colon, men 25% and females 23%. And then rectum 22% in male and 27% in females. And the cecum, males at 11% and the females at 10%. Approximately 1/2 of all colon cancers happen in the rectosigmoid area. So whenever colon cancer metastasizes, these are the common sites: the lymph nodes, the liver, lungs, bones, and the brain. The complications, like we talked about, include obstruction, bleeding, perforation, peritonitis, and fistula formation. So diagnostic studies, fecal occult blood tests. So we look for blood in the stool, but this is not the gold standard. The gold standard will be a full-on colonoscopy with biopsies taken. And then the limitation of the fecal occult blood test is that it does not detect non-bleeding tumors. And what should the patient be taught about the tests? I will say not to eat foods with red dye. For the colonoscopy, the entire colon is examined, biopsies can be obtained, polyps can be immediately removed, and like we talked about previously, patients should be NPO, and then they'll do the prep with the Go Lightly, and then for 24 hours prior to the procedure, they should be on a clear liquid diet. This is a blood test, carcinoembryonic antigen, so complex glycoprotein produced by 90% of colorectal cancers. And then this is helpful in monitoring disease recurrence. So instead of having the patient do, once they've been diagnosed and they've undergone treatment or surgery, instead of having a patient undergo colonoscopy every time they want to check for recurrence, they just do this test. Those are some ugly colons. Oh my gosh. So the clinical manifestations for left-sided lesions, rectal bleeding, alternating constipation and diarrhea, change in stool caliber, sensation of incomplete evacuation. And then on the right-sided lesion, they are asymptomatic, that is not good, vague abdominal cramping, and then colicky abdominal pain. So if they are asymptomatic, it may take a while, and unfortunately, the longer you wait, the higher chances of spreading or malignancy. Metastasis, I mean. So patients can either undergo chemotherapy or biologic and targeted therapy, 2 monoclonal antibodies to block epidermal growth factor receptor, and then prevents angiogenesis. So those two different chemotherapies. Radiation therapy is used post-op as an adjuvant to surgery and chemotherapy, or as palliative therapy for metastasis. So if it's untreatable, then they're using radiation therapy to basically alleviate symptoms for the patient. So for colon cancer, unfortunately, surgery is the only cure. Polypectomy during colonoscopy is used to resect colorectal cancer in situ. If cancer is localized, then it can be resected with healthy tissue and cancer-free ends sewn together. And the lymph nodes are removed to prevent spread. Here are some of the common sites for colostomies. And so depending on the area of the colostomy, that is how you know the stool consistency will depend on the area of the colostomy. Sigmoid colostomy. So the distal bowel is oversewn and left in place to create Hartmann's pouch, which is that. And then double barrel colostomy right wall reanastomosed in 3 to 6 months. Okay, assessment of ostomy. So this is a good slide for you guys to pay attention to. A good ostomy is pink or red, and it's raised and it's painless. There might be slight bleeding, not extensive bleeding. And then abnormal if it's pale or dusky. So this basically means that there is no circulation to the opening. So whenever you're assessing your patient's ostomies, make sure they are pink or red, and be sure to document that on your on the chart. And then also especially in the like a day or two after surgery and you notice that it is pale or dusky, the physician should be notified right away, because this means no circulation. And then if there's hemorrhage, separation, and then when caring for the stomach, be sure to pay attention to the skin around it, just basically to keep it clean so it does not cause breakdown. Make sure the appliance has a proper seal and should be proper fit. Odor control, dietary management, and irrigation. So before a patient gets an ostomy, they normally go through some form of teaching with the ostomy nurse, and it's also good to introduce these patients to like a support group, because when you think about it, this is basically going to alter their body image, and it's going to have a huge significance in their life. So we have to prepare them mentally one way or the other. Oh, there it is. So psychological support. Patient may need to have chemotherapy as an outpatient, and appointment with the enterostoma therapist must be taught wound management and stomach care. Like I was mentioning before, this should happen ideally before they have the surgery and after the surgery. And this is the end of this slide. Be sure to review what kind of foods for patients the patients need to avoid in IBS, inflammatory bowel. And then, like I mentioned, ileostomy post-op day 1 should not appear dusky. It should be red. And then in acute diverticulitis, how will you assess for that? How will the patient be presenting?